In an ideal world, we would like to have a product that doesn't need any medication and that promotes endothelialization as well as inhibits thrombogenicity at 100% level, to have just the perfect implant that fits for all different neuroendovascular treatment areas such as ischemic stroke and hemorrhagic diseases. But as we already have good products for the majority of all cases, we're focusing on special situations such as acute ruptured aneurysms or intracranial rescue stentings in stroke treatment. And this is where we're limited to a very non-aggressive antiplatelet regimen, because the patient might be exposed to a severe hemorrhagic risk in terms of bleeding again from the same aneurysm, or bleeding during neurosurgical procedures such as ventricular drainage. And in the ischemic stroke cases, we're facing situations in rescue stentings with the worst thrombectomy patient population that we can already have. And this is where we would like to treat patients at least under mono antiplatelet therapy. So having a product that reduces our current scheme would be very helpful. I think HEAL, with its different mechanisms of action, could help in aneurysm treatment by promoting the endothelialization and faster healing with neck remodeling. And it could also, with its property of needing less antiplatelet drugs, give us the opportunity to treat acutely ruptured aneurysms under mono aspirin or mono PY12 inhibitor therapy. So it would enlarge the spectrum of indications for endovascular treatments, as well as in ischemic stroke as in hemorrhagic stroke procedures. I think, given the fact that we consider HEAL to be a coating that has at least 3 different properties of action, it should be eligible in almost all cases. And even if we don't know whether we need it in elective cases under, let's say, double antiplatelet therapy in a patient that was well prepared and tested to the antiplatelet reaction, we should still consider to provide these products also in elective cases, because the patient might have any secondary complications where we are in a situation to be forced to reduce the platelet regimen. So if it was my brain, I would like to have the product that fits all situations, even the ones that we cannot predict. And these are well known in neuroendovascular therapy and might appear after any procedure. So I really see a broad spectrum for indications for the coated products. Yes, just recently, 2 weeks ago, we had a patient with a ruptured anterior communicating artery aneurysm, and the patient did well. The aneurysm was coiled without any complications. The patient didn't need any anti-aggregation management because we didn't need a stent. It was a simple coiling procedure. But due to the initial aneurysm rupture, the patient had a massive SAH and an ICH in the frontal lobe. So the patient needed ventricular drainage, and after 10 days the patient developed severe vasospasm, and during this vasospasm phase the patient developed a thrombus at the origin of the aneurysm. So we had to go back into the same artery, the parent artery of the aneurysm, and what we found there was a thrombus formation, and we stented this thrombus together with the broad-based coil package at the aneurysm neck with a CredoHeal 3 by 20 millimeter stent. and we only gave 500 milligram of aspirin IV and kept the patient on this drug for 10 days now. And since the patient now needs ventricular peritoneal shunting, neurosurgery will probably also stop the aspirin therapy. So we feel quite confident in this patient that after the cranial implantation under aspirin monotherapy never developed any new thrombus and never developed any new symptoms. So this is our most recent successful case where we see some benefit of the heel coating. It would have the property to cover the struts of the stent by endothelial growth promoting surface with a 0% of thrombogenicity, but it will also have some influence on the gaps between the stent struts. Because if we talk about rescue stenting, we are not only talking about the athrombogenic struts of the stent, but also we're talking about the gaps between the struts, which is more than 90% of the vessel surface. So what we see there is either atheroma or fresh thrombus. At least it's a very rough vessel surface. And this surface is not covered by the stent, of course, because the struts do not cover 100% as they are not covered stents. And this would be the ideal product that has some influence by a drug acting also between the struts and making the vessel surface unavailable to any secondary thrombus growth.